Welcome to Wisdom Radio. I'm Dr. Rusty Hofmann, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
You know, when you deploy a stent in the arterial system, there's a pretty distinct mechanical predictability to it.
Right, yeah.
You cross the lesion, prep the vessel, deploy the scaffold, and as long as your runoff is adequate, you can walk away confident. The hemodynamics are working with you. They're pushing forward with systemic pressure. But you step into the cath lab for a venous stenting procedure, specifically for chronic venous obstruction, and the technical success in the lab does not always predict what you will see months later.
Oh, absolutely. It's night and day.
Right? A well-sized stent that looks expanded on the table might just thrombose in 3 weeks. It's one of the defining frustrations of deep venous interventions.
It really is. And, the physiology is just different. In the venous system, we're relying on low flow, low pressure.
Right.
So even minor morphological variations or just the slightest degree of stasis can tip the scales right from patency to stent failure. We're essentially fighting the coagulation cascade in a very sluggish environment.
Which brings us to the core of today's deep dive. We're looking at 2 new retrospective papers that confront this predictability problem head-on.
Yes, 2 very relevant papers.
So the first is a 2024 multicenter study from the European Journal of Vascular and Endovascular Surgery, EJVES, and they propose a 5-tier anatomical classification for chronic venous obstruction based on morphological extent.
Right.
And the second is a 2024 single-center study from JVIR. Now, that one isolates and analyzes the specific impact of inflow disease and post-thrombotic syndrome. So the mission here is to figure out if we can accurately predict primary patency loss, guide our procedural planning, and, set realistic expectations for patients before they are even prepped on the table.
I think to set the clinical baseline here, we first have to look at the wide variance in outcomes. Because if you treat a non-thrombotic iliac vein lesion, a classic NIVL, the primary patency approach is 100%.
Basically a sure thing.
Right, because the anatomy is pristine. It's merely an issue of extrinsic compression. But the moment you transition to treating severe post-thrombotic syndrome, primary patency drops into the 50s.
Wow.
Yeah. So the clinical question driving both of these papers is determining exactly how distal anatomical extent and compromised inflow dictate that specific failure rate.
And the patient population in these cohorts is highly specific, right? Like, these are not just incidental findings.
Not at all. Both studies focus on highly symptomatic patients presenting with CEAP classes C3 through C6. We are talking about moderate to severe PTS with Volta scores over 10.
Often driven by venous claudication or active recalcitrant ulceration.
Exactly.
Correct.
And the underlying pathology in that C3 to C6 cohort is what sets the stage for the failure. I mean, we aren't dealing with simple stenosis here.
Right, it's much more hostile.
Post-thrombotic synechia are these web-like fibrotic bands that essentially turn a high-volume conduit into a low-flow sieve. The vessel wall loses its compliance, the valves are destroyed, and the trabeculations disrupt the laminar flow that you need to keep a metallic scaffold washed out.
I struggle with this clinically, and I think it brings up a real tension in the data. Let's say you have a patient in the clinic with the Volta score of 15.
Okay.
They have severe claudication, maybe an active C6 venous ulcer. My instinct as a physician is to intervene to relieve that suffering.
Naturally.
But then you look at their preoperative imaging, and their inflow architecture is just heavily fibrosed. How do we reconcile the subjective severity of their symptoms with an anatomical assessment that essentially tells us extensive inflow disease substantially increases the risk of primary patency loss?
Well, it's the defining dilemma of patient selection in PTS. The severity of the clinical presentation correlates with the severity of the deep post-thrombotic changes. I mean, the pathophysiology driving the ulceration is the same pathophysiology driving the trabeculations. You can't decouple the clinical misery from the anatomical reality. If the anatomy dictates a lack of inflow, placing hardware without modifying that flow dynamic will result in thrombosis, regardless of how high the patient's initial Volta score was.
Which means we really need a precise, standardized way to categorize that anatomy before we intervene. And the EJVES paper attempts this with their 5-type system. I think it's worth mapping this out geographically down the leg.
Yeah, let's go through it. The classification moves proximally to distally, tracking the progression of the disease.
Starting with type 1.
Right. Type 1 is your baseline non-thrombotic iliac vein lesion. There's no post-thrombotic fibrosis there, just the mechanical compression, typically at the iliac crossover. Type 2 represents chronic venous obstruction confined to the iliac segment. It is post-thrombotic, but the disease burden stays high up in the pelvis.
Got it. And then type 3 is where the hemodynamic game kind of changes, right?
Exactly. Type 3 is iliofemoral chronic venous obstruction that extends down but stops just above the common femoral vein confluence.
So it crosses the inguinal ligament?
Yes, which introduces mobility and external compression issues, but it spares the deep inflow vessels.
Okay, so then we hit type 4, and this is where the prognosis really shifts. It's subdivided based on which inflow vessel is actually compromised.
Right. Type 4A extends into the femoral vein. Type 4B extends into the deep femoral vein. So now the disease is actively obliterating one of the two main inflow conduits.
And finally, type 5 represents the obliteration of both the femoral vein and the deep femoral vein, basically a worst-case scenario.
Exactly. Now, if we look at the JVIR paper, they tackle this same anatomical problem, but from the perspective of inflow quality rather than just geographical extent.
Right. They grade inflow based on the presence of post-thrombotic trabeculations and vessel caliber.
Yeah, they use 3 categories: absence of inflow disease, single vessel disease, or double vessel disease.
Which feels pragmatic for the operator. Like, a normal caliber vessel with no trabeculations gives you adequate volume. But if the vessel is small, thick-walled, and heavily trabeculated, they grade it as poor inflow regardless of how far down the leg the disease physically extends.
To put this in mechanical terms, think of it like a peripheral bypass graft.
Oh, that's a good analogy.
You can deploy a well-sized 14mm or 16mm main conduit, your stent, in the iliofemoral segment. But if the runoff or feeder vessels, the femoral vein and deep femoral vein, are choked with trabeculations, you lack the required volume.
It just won't stay open.
Exactly.
Yep.
It does not matter how optimal your stent expansion is on the table. If the volume of blood entering the stent from the calf muscle pump is just a trickle, the resulting stasis triggers the coagulation cascade and the stent goes down.
Because stasis is the primary enemy here.
Absolutely. The volume required to keep a 16mm venous stent open is substantial.
Yeah.
When the disease progresses to a type 4 or type 5, the residual venous capacitance simply cannot deliver that volume. And because that fibrotic anatomy chokes the flow, deploying a standard stent is often just insufficient, which forces operators into some pretty aggressive procedural modifications.
So let's unpack those procedural mechanics, because crossing the inguinal ligament into hostile inflow requires technical shifts. Both studies reflect a transition away from non-dedicated platforms like the older wall stents toward dedicated venous nitinol platforms.
Yeah, the operators in these cohorts are primarily utilizing platforms like the Abre, Vici, Venovo, and Sinus XL.
And EJVES is heavily featured.
Oh, universally utilized. EJVES is not treated as an adjunct here. It helps to assess the true extent of the intraluminal trabeculations and to ensure you aren't jailing a critical inflow vessel when landing the stent at the confluence.
But the technique modifications for those extreme cases, the types 4 and 5, that's where the procedural complexity really peaks. In the EJVES cohort for those type 5 cases, operators utilized hybrid procedures in up to 27% of the cases.
27%. That's a significant chunk.
It is. We're talking about combining endovascular stenting with open surgical endophlebectomy at the groin to physically core out the post-thrombotic synechia.
And even beyond the endophlebectomy, when the coring out is still insufficient to guarantee flow, operators are creating an arteriovenous fistula, an AVF, to artificially boost inflow.
Right. Think of the AVF as priming a dry pump. You have the stent, but no volume coming up from the leg. So by creating a fistula between the superficial femoral artery and the femoral vein, you're artificially hijacking arterial systemic pressure and volume.
You're forcing it up through the venous stent to keep the struts washed out while the endothelium heals.
It's a hemodynamic manipulation.
It is, but it highlights the baseline physiology of a type 5 limb. Without that arterial pressure masking the venous stasis, the hardware fails. And this requirement for high flow also dictates the aggressive pharmacological regimens they used in these cohorts.
Right, let's talk about that.
Intraoperatively, standard IV heparin is utilized, as you'd expect, but the postoperative management is rigorous.
Both cohorts mandate an immediate bridge to low molecular weight heparin. But The duration and transition strategies sort of diverge. The JVIR cohort transitioned patients to VKAs or DOACs at 2 weeks for patent stents.
While the EJVES protocol mandated a minimum of 3 months of therapeutic systemic anticoagulation frequently with heparin before even stepping down to an oral agent.
That is a long time to keep someone on heparin.
It is. Additionally, the JVIR data shows antiplatelets were used in roughly 30% of their single and double vessel disease cohorts.
So they're targeting both pathways.
Exactly. Utilizing a multi-pathway approach, hitting the coagulation cascade and platelet aggregation to prevent thrombosis in these low-flow environments.
Hey listeners, it's Rusty Hofmann from Stanford jumping in here. There's another podcast on the use of antiplatelets in venous stenting that's worthwhile listening to. Bottom line, you don't need to use them, but in this paper, they did use them. Please take a listen to an earlier podcast.
And this aggressive pharmacological and hybrid surgical approach brings us to a critical data point in the EJVES paper.
This is where it gets tough.
Yeah, in the EJVES cohort, major bleeding occurred in 4.4% of type 4 patients and 5.3% of type 5 limbs.
Which is high.
It's very high. This morbidity is largely driven by the hybrid endophlebectomy and AVF creation. We really have to question whether the surgical morbidity of a hybrid approach is justified for, a marginal patency gain in a limb that is already hemodynamically compromised.
That 13% major bleeding rate is the crux of the multidisciplinary heart team debate. I mean, you are attempting to heal a C6 ulcer or relieve claudication, but you're introducing a high risk of bleeding and significant wound complications in a groin that already suffers from poor tissue quality and venous hypertension.
Right.
It requires a rigorous risk-benefit analysis tailored to the patient's physiological reserve.
So, assuming we have navigated the procedure, managed the bleeding risk, and titrated the anticoagulation, what do the Kaplan-Meier curves actually reveal about stent survival over time?
Well, the EJVES paper outlines a very distinct stepwise degradation in patency that aligns perfectly with their morphological tiers. At 12 months, primary patency for type 1 is 95%.
Great numbers.
Type 2, the isolated iliac chronic venous obstruction, drops slightly to 90%.
Which is still an acceptable outcome for an endovascular intervention.
It is, but crossing the inguinal ligament changes the trajectory. Type 3 primary patency drops to 81%. Type 4 falls to 61%.
Wow.
And type 5, the double vessel inflow obliteration, demonstrates a 39% primary patency rate at 12 months.
Let's just hold on that number for a second. 39%. We are stating that 6 out of 10 patients with type 5 disease will lose primary patency within 1 single year.
And the JVIR multivariable regression data isolates the mechanism behind that failure rate. When analyzing their variables, single vessel femoral vein inflow disease alone yielded an odds ratio of 10.99 for primary patency loss, because the femoral vein is the primary conduit for the volume generated by the calf muscle pump. The deep femoral vein provides collateral flow, but the ephemeral vein handles the bulk of the clearance. If the ephemeral vein is heavily diseased, the shear volume of inflow drops below the critical threshold required to maintain shear stress along the stent struts. The stasis sets in, and thrombosis is inevitable.
However, both papers present a crucial data point regarding secondary patency.
Yes, they do.
Even when these stents fail in thrombose, if the failure is identified early through surveillance, secondary patency remains high. Both papers show secondary patency in the 80 to 90% range across the board, even for the complex type 4 and type 5 morphologies.
And that secondary patency data requires a specific framing when presenting these cases to colleagues. Stenting a type 4 or type 5 chronic venous obstruction is not a definitive single-stage procedure.
It's a pathway.
It is a commitment to a re-intervention pathway. You may buy the patient the necessary time and flow to heal an active ulcer, but you must counsel them that they will likely be back in the cath lab within the year for catheter-directed thrombolysis, venoplasty, or stent relining.
So translating this to our current practice, how does this morphological data fit into our guidelines? And maybe more importantly, where do we need to scrutinize the author's conclusions?
Well, from a guideline perspective, this data refines the ESVS 2022 guidelines. The European Society for Vascular Surgery supports stenting for severe PTS. However, historical guidelines have lacked specific anatomical boundaries for that recommendation.
They were pretty vague.
Exactly. These papers provide the morphological limits, demonstrating where the risk-benefit ratio inverts based on the inflow disease.
But while the anatomical classification is practical, there are methodological flaws we absolutely need to address. I want to push back on a specific finding in the EJVES multivariable analysis.
Okay, let's hear it.
The authors identified the total number of stents as an independent predictor of failure alongside the CVO type.
Right. They utilized stent quantity as a proxy for lesion length and disease burden.
And I argue that total number of stents is a flawed proxy for disease extent.
How so?
Think of it like measuring the condition of a road by counting the number of asphalt patches used to repair it, rather than just measuring the actual length of the damaged road. If you're using a dedicated platform like the Vichy stent, which often maxes out at shorter lengths, you have to deploy more stents with more overlap zones to cover the same 150 millimeter lesion length compared to using a single long platform like an Abre or Venovo.
Ah, I see. The inventory available on your shelf confounds the variable.
Exactly.
3 short overlapping stents do not mean the disease is worse or more prone to failure than a single continuous 150 millimeter stent.
Right. So using stent count as an independent predictor is imprecise and misleading for the operator trying to plan a case.
That is a fair critique of the EJVES data. And similarly, the JVIR methodology has limitations regarding subjectivity. Their entire premise hinges on the grading of inflow,
Which they graded visually.
They categorize inflow as good, fair, or poor, based on a visual assessment of trabeculations on venography or duplex ultrasound.
The eyeball test.
Precisely. Without quantifiable flow volume thresholds, meaning volumetric data measured in milliliters per second via EJVES phase contrast MRI, inflow disease remains an eyeball test. An assessment of fair by one operator might be graded as poor by another. We need flow metrics to validate these predictive models.
Furthermore, because both of these studies are retrospective, the survival analyses inevitably suffer from missing follow-ups. In Kaplan-Meier curves, missing follow-ups frequently lead to favorable censoring.
Right, the patients who are lost to follow-up are statistically assumed to be patent.
Which likely inflates the long-term patency numbers artificially. The true primary patency at 2 or 3 years for a type 5 lesion may be even lower than the 39% reported at 1 year.
It is a common limitation of retrospective core lab data. The real-world patency experienced by high-volume operators is often more sobering than the out-year projections in these publications.
Which leaves us with a final thought. Looking at the failure rates for these complex lesions, we really have to ask if we are reaching the mechanical limits of what endovascular hardware can achieve for severe post-thrombotic syndrome.
That's the million-dollar question.
Right. We are deploying highly engineered nitinol scaffolds, but without altering the underlying venous hemodynamics, the lack of flow eventually just wins.
The hardware platforms have evolved significantly, but the post-thrombotic physiology remains unforgiving.
If these papers are correct, they could improve how we risk stratify patients before intervention, helping identify those who may be at higher risk for reintervention and setting more realistic expectations during pre-procedural counseling. To solidify this finding, we need a prospective trial utilizing standardized EJVES and flow volume measurements to establish objective hemodynamic thresholds for stent failure.
That's all for today. Thanks for listening.
Hey, it's Rusty Hofmann, professor of interventional radiology at Stanford. I've spent my clinical career doing venous stent and thrombosis research, and these are really interesting articles that I'd like to just provide a commentary on. So what I believe to be true, although we don't have any data other than what we did initially, was, what is the diameter of a good inflow vessel? And what I've been using for my career is the femoral vein, or the inflow needs to be 8 millimeters in diameter. When we designed the Cook-Zilver Vena trial, which was the first ever venous stent trial designed, we used that diameter as the empirical threshold, that if it was smaller than that we would not allow enrollment of the patient. So that's what I've used, and I found it helpful. Number 2, when the femoral vein is out, I have had patients, and again, this is anecdotal, but if they have a large, deep femoral vein that's hypertrophied that approximates the diameter like 8 millimeters or bigger, as we use in the femoral vein, I will leave the stent in the common femoral vein with the inflow from the deep. Now, I never stent into the deep femoral vein. I've seen cases of that, and this is, again, anecdotal. But these practices of the 4 points that I'm going to be making is really the basis of the paper that we published, and we'll do a podcast on it, the 20-year Stanford experience that came out, I think in JVIR 2018 or 2019. The next question I've been asked every time I talk is, can you stent below the inguinal ligament? And absolutely, positively can. We've been stenting below the level of inguinal ligament for 30 years here at Stanford, and you can stent as low as the lesser trochanter.
Again, when we do our paper from Stanford, we can talk a little bit more about that. You need to stent into a healthy vessel that's at least, or even a disease vessel that's at least 8 millimeters in size. And then finally, the authors talked about the total number of stents as a predictive. We did a deep analysis. I always thought that that was possibly true, but we studied our 400 patient database with the paper that we will be discussing in the future and found that the number of stents was not an independent predictor of stent thrombosis. So I hope you've enjoyed the pods. There'll be more to come on the venous space. Take care.
And that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.